John and Laura, maybe I'll just start with, since it's 12:04, I'll give a few starting words before you launch into things, if that's okay. So welcome everybody. It's nice to see people from around the city. It feels like a long time, well, obviously ancient since we've seen each other in person, but even a long time since we've had these rounds. So really great to see people. I had originally booked an actual in-person gathering for November, but obviously that's not allowed. But in December, we'll have another virtual holiday rounds with a competition and a trivia quiz as we did last year. So we'll see if Sunnybrook and Zach will maintain their championship or if someone else will take the crown, the trivia crown. But today, I'm really delighted to have Dr. Jonathan Mong and Dr. Laura Rodger presenting. As you know, they're both grads of our GIM subspecialty program, and they both have extra training in addictions medicine. And so I'm really delighted that they'll share their expertise with us. They're both working as clinical associates at U of T this year. A reminder that these rounds are accredited by the Royal College, 1 hour Section 1 credits. If you need a formal certificate, let Tina know. There will be an evaluation coming afterwards. Please complete it. Feel free to use the chat to ask questions and to socialize a bit. That's part of the nice part about these rounds. And at the end, during the question part, when the slides are done, if you feel comfortable, please put on your camera so we can see each other. And anyone who's working from home, we want to see your children and or your pets. So over to you, John and Laura.
Sounds good. Yeah, and Schiffer, I didn't know that there are 821 other John Mongs either. So that's news to me. I learned something today as well. So hello, everyone. I'm John. I'm a clinical associate, mainly working at TGH, part of the UHN Opioid Management Working Group. For those of you who I haven't met before, hello. I did my residency and fellowship in GIM here at U of T, went to TOH for a year, worked with the substance use team, worked with the GIM team, did my master's in quality improvement, and I'm back here.
I'm Laura. Hopefully if you see me in person, please say hi. I'm mostly at St. Mike's. I'm also a little bit at the Western, and I work with the addictions team here at St. Mike's as well.
So we'll be talking to you today about hyperglycemia. And just a few things to start off. Want to acknowledge that Toronto is the traditional territory of many nations, including the Mississauga of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. Of course, many other groups and nations as well, Inuit and Métis peoples. I want to say thank you to a bunch of the organizations that helped train us and some individuals specifically, Tarek and Paxton, who helped us refine and put together this presentation. And neither of us have any financial disclosures to make. If you want to find us after, so that we do, please let us know. Now, before we get on to the presentation, I just want everyone to get familiar with Pull Everywhere. And I want you to do that by helping me settle what might be a bit of a contentious question. Some of you may have heard that I was in Germany recently on vacation. My wife and I went to the Alps, namely the Zugspitze, which is the tallest peak in Germany. This is my way of enjoying the Alps, eating an overpriced mousse and an overpriced hot chocolate. Meanwhile, this is my wife, Daisy. She takes a much more active approach to enjoying the Alps, loves hiking, really walked around the glaciers, a bit to my chagrin. So I want to ask you folks, oh, okay, well, not that I'm biased at all, but hey, someone's already said John's way is better. But which way, oh, someone said, really? Come on, it's not just, am I that unlikable? You shouldn't have said anything. I shouldn't have said anything. It's true. I feel like a teleprompter sometimes, like text A to, 37, okay. Okay, we'll stop there because well, fine. I'll pretend that some people's fingers slipped and hit B instead of A. So I won't tell my wife, it's okay. So these are the learning objectives, and I won't go through them in detail quite yet. So we'll start with a case study, right? Let's say you're on team, you're seeing a 25-year-old woman with type 1 diabetes. She's on huge amounts of insulin that have been carefully adjusted and titrated and works for her. And she comes in with, a cellulitis. Easy peasy. She's got mild hyperglycemia. She's admitted, she's put on IV antibiotics. Her home insulin isn't ordered. She's just put on a low-dose sliding scale. Over the next 24 hours, her cellulitis improves. Great. But she has ongoing hyperglycemia. She says, hey, I need much higher doses of insulin. This isn't how my hyperglycemia is managed. But the team feels uncomfortable. They're especially worried about hypoglycemia. They're not comfortable with insulin. And 72 hours after admission, she develops DKA because of untreated hyperglycemia in the patient with type 1 diabetes. Now, you might say, wait a second, John, two things. Number one, we would never treat a patient with type 1 diabetes and hyperglycemia like that. That's ridiculous. What are you talking about? Number two, I thought this was a talk about opioid withdrawal management. And you're right on both counts. So instead of this patient having type 1 diabetes, I'll tell you about a real patient that I saw when I was a PGY1 at the Western. Exactly the same case, except instead of type 1 diabetes, she used opioids. And we on the team didn't feel comfortable with giving the high doses and adjusting the doses of opioids that she needed to feel comfortable and to treat her opioid withdrawal. And she ended up self-initiating discharge. And on the face of it, patients with type 1 diabetes and patients with opioid withdrawal, there's a lot of similarities. You know, insulin doses need to be escalated and up titrated, and they're going to be different for each individual. There is a safety risk with hypoglycemia or potentially overdosing opioids. And we need to make sure that we are comfortable with managing these medications. So as we go through this talk, I kind of want to keep that analogy in mind. How can we make treatment for patients with opioid use disorder and withdrawal similar to how we treat patients in up titrating insulin for type 1 diabetes? So this is the real talk, as I'm sure you may have guessed by now. And these are some of the questions that you folks have asked. What to do when the pharmacy or hospital is not allowing you to initiate yada, 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 yada. And that's zooming in a bit. And, you know, I'm sure we'll see a lot of the other questions along the way. So we'll start off with the first learning objective, which is to describe the importance of managing opioid withdrawal for admitted patients, i.e., why do we care? You know, why is this an important topic? And there's 4 main reasons for this. Number one, you don't need me to tell you this. You all know about this. You've seen the news stories. You've seen it yourselves on clinical service. It's common. All right, this is data from the Ontario Opioid Tracking Tool. And you can see in Toronto, since 2015 and the introduction of Fent into the drug supply, ED visits and deaths have just gone up incredibly, right? For something a bit more local, when we look at monthly admissions to UHN for patients with opioid use disorder, opioid withdrawal, you know, it goes from anywhere from 3 to 20 a month. And you might say, well, you know, that's not that much. If you think about it, that's like 100 to 200 a year, depending on the monthly volumes. And when you compare it to something that's a slam dunk as a COPD admission, where you get 490 a year, you know, if something's about half as common as COPD, I would hope that we as internists are able to have that expertise and knowledge to be able to adequately care for these patients. And, you know, to flip it on its head, we've been all super worried, understandably, about COVID for the past year and a half. Imagine if these are COVID numbers. You know, these are young people in their 40s and younger who we're seeing, who we can be taking better care of. The second thing is that it helps patients feel better. And as a result of that, it really impacts healthcare use and healthcare delivery. Those of you who've been in hospital know that it's really not a very pleasant sensation, or maybe you've had a loved one who's been in hospital. You know, the sort of joke that I always tell patients is, well, it's Toronto General Hospital, not Toronto General Hotel. Now imagine all the terribleness and the bad feelings of being in a hospital already, and then throw all of these symptoms on top of it. This is a comic or an illustration of what opioid withdrawal symptoms are. You know, you can, I won't focus too much on what the actual symptoms are, but you can tell it's not a fun time, right? People are suffering when they're in opioid withdrawal. They have bad emesis, diaphoresis, you know, goosebumps, diarrhea, they have cramps all over. So is it any wonder that patients who experience opioid withdrawal, they are much more likely to self-initiate discharge because, you know, they feel, probably correctly, that they could manage their symptoms better outside of the hospital. You know, patients who use drugs are 30 to 50 times higher to self-initiate discharge. And not only that, but it is, you know, fear of withdrawal is a major reason that's been identified why this population is hesitant to seek care in hospital. The third really interesting point as to why we need to be familiar with opioid withdrawal is that there's this concept of losing tolerance, which then leads to higher rates of unintentional overdose after discharge. If you can imagine someone who's normally using 6 to 9 points of fentanyl a day, they come into hospital, they're admitted for 2 or even 3 days or longer for treatment of something like a cellulitis, and we don't keep up their opioid tolerance by providing them with their opioid needs, over that period of time, they will lose their tolerance. And just like after a stay in prison, after a stay in hospital, there is now evidence to show that patients are at higher risk of an unintentional overdose. And this was actually just released last month, 1 month ago today. And the risk is 2 to 4 times higher of an unintentional overdose after a hospital discharge. And that's presumed to be due to this loss of tolerance because patients are not able to keep up with their same amount of opioid use inside the hospital as they were before coming into the hospital. And then they're using the same amount that they expect to use prior to admission, and then they accidentally overdose. So to me, that's a huge reason, a huge impetus to make sure that we don't accidentally make patients lose their tolerance. And saving the best for last, opioid agonist therapy and starting treatment saves lives. And, you know, internist, everyone here is an internist. We're used to NNTs of, 20, 30, 40, 50. But when you look at, methadone and Suboxone for treatment after a non-fatal overdose, we're talking about NNTs of 2 to 3, single digits, right? And to me, that is absolutely, it almost becomes a moral imperative at that point that we become familiar with these medications. This study was published 3 years ago, and you can see that it decreases mortality, not only for overdose related or opioid related causes, but also non-opioid related causes. And so, to summarize why we as GIM need to be comfortable, it's common. We all knew that. Number 2, we like making patients feel better, right? That's one of the main reasons we became doctors, I'm sure. And because of that, it can impact healthcare use and delivery, right? We want to make sure that patients feel comfortable in hospital, that they're willing to seek care because they know that their symptoms will be treated. We want to try and prevent those unintentional overdoses after discharge from loss of tolerance. And NNT of 2 to 3 saves lives. So that's it for learning objective number 1, and I'll pass it off to Laura now to talk about number 2 and 3.
Okay, so we'll get into the actual specifics about withdrawal, how it's assessed, and then we'll move on into some of our management principles. Oh, okay, so, and we're just going to start with our poll question. If you have a chance to read it, we want to know which of these statements is not true about opioid withdrawal. So we'll just give it a minute. Okay, I really don't know if it's one person or more than, okay, there we go. All right. So the majority is none of the above. So we'll try to address all of these factors in the next couple of slides. So first thing is we have to be thinking about opioid withdrawal. And so when we think about opioid withdrawal, most of us were trained more familiarly with the pharmaceutical opioids. So things like our traditional short-acting medications and then our extended release medications. And so the withdrawal period tends to be much more predictable for those types of pharmaceutical preparations. So for short-acting opioids, it's pretty quick onset, lasts a couple of days. Long-acting, you see a little bit more of a delayed onset, and it can last for a little bit longer. Things like methadone are in a bit of a more special category because of its long half-life and variable half-life. And so people can actually sort of have a subacute withdrawal period with changes in methadone. However, this has become a lot more complicated in the era of fentanyl. And so fentanyl, with all of the different things that actually come in our street fentanyl, the withdrawal tends to be fairly unpredictable, and it's been a lot more challenging for a few different reasons. So fentanyl is not just fentanyl. And so for anyone who's interested, I've just highlighted the Toronto Drug Checking Services there. And this is a report that you can get by email or information you can look up online, and they'll test either used paraphernalia or samples that patients or people can bring and drop off, and they'll run it in the lab and they'll tell us what's in it. And so we know that street fentanyl has a lot of benzodiazepines. There's a lot of other synthetic opioids that are present. And so this makes the withdrawal course much more unpredictable. Fentanyl substances are also fat soluble. And so there's some people who think that it's actually persisting for much longer. And so the withdrawal can be actually protracted, prolonged, or not present or occur until, 24 or 48 hours after somebody has fentanyl or uses fentanyl or overdoses with fentanyl. So it's a lot going to rely on your clinical judgment and your clinical assessment. The other thing that we're traditionally taught when we start to talk about withdrawal, even as early as medical school, is dividing things into quote unquote life-threatening withdrawal and things that are not. And so while opioid withdrawal is generally thought of as one of those more, less severe presentations, there can be very significant complications if somebody's in severe opioid withdrawal. And so we did a bit of a survey of the literature to see some of these things. And so you could imagine, of course, with significant nausea, vomiting, and diarrhea, you could get profoundly hypovolemic. With vomiting and recurrent vomiting, people can develop esophageal tears and complications associated with that. We have examples of rhabdomyolysis and also Takotsubo cardiomyopathy, which is felt to be related to the significant sympathetic surge that happens in that withdrawal state, that sympathetic activation that patients are experiencing. So how do we measure this? How do we assess this? How do we follow this? So we use COWS. I'm hoping everyone is at least a little bit familiar with COWS. It's a standardized and validated assessment tool. You score your parameters and your score reflects the severity of withdrawal. I want you to keep in mind that number of 12 to 13, where that cutoff is, where people enter that moderate withdrawal phase, because that has a lot of implications for our medications like buprenorphine, naloxone, or Suboxone, as you know more commonly. Just a tiny bit of background. Analogous to CWA and very much modeled after CWA, there are some caveats that we all know about with our CWA scores. So when some measures are more subjective, it can be a little bit more challenging. But fortunately, as you'll see, I think most of the COWS scores are actually fairly easy to appreciate at the bedside. It can be done very quickly, and it's used in a whole bunch of different places. I've also had a lot of residents, medical students, even nursing staff that we've introduced this to for patients that I've been, providing care to, and people are fairly reliably able to execute a score. So I would encourage you to familiarize yourself with the score and use it with patients, even though there may not be as much, protocolization of it as with our CWAs. So here you can see the components of the COWS, and we'll go through it in a little bit more detail. And so, as I said, a lot of these things can be objectively appreciated. So things like the heart rate, pupil size, although again, that can be a little bit difficult, but you're looking, are they really big? Are they really small? People can have a lot of rhinorrhea and lacrimation. They can be yawning. It's pretty easy to appreciate if somebody has really significant piloerection. And so a lot of these things are actually very observable. And so you'll sum the score, and that'll tell you at that current moment in time about, the symptoms that someone's having and if you think they could be attributed to withdrawal. So going back to this poll, I'm not sure, are people able to change answers? I don't know.
They are.
So if anybody wants to take the opportunity to change their answer. So we would say that, yeah, so the withdrawal from fentanyl is fairly unpredictable, and all of the other statements would be considered true. Okay, so then what do we do about this? We identify someone's in withdrawal, we're following their COWS score. What are the actionable things we can start doing as clinicians? Oh, whoops, sorry. So as a bit of a primer, because a bit of a spoiler alert is that the withdrawal management parallels very much just general management of opioid use disorder. So we just have a poll question about opioid agonist therapy.
I do feel like a horse race watcher whenever seeing a poll. It's like, oh, people are going for A, people are going for B. What's going to be the answer? What's like, we'll come back to it at the end. Thank you, everyone who's participating. And it kind of looks like A is the clear winner so far, which is really good because we'll have a lot to chat about.
Horse racing just reminds me of Squid Game now. All right, so what can we do? So we'll go through most of these treatments. We're not really going to address IO, so injection therapy, but we'll start with sort of the most basic immediate things that you can do. So supportive care. Supportive care essentially means detox. And what we do know is that detox is not, and I apologize if this is a bit of an obvious statement, but detox is not treatment for an opioid use disorder. And so we know that if people sort of do this cold turkey, there's a very high risk of relapse. And so when people are presenting in withdrawal and we want to initiate therapy, we want it to be both supportive, but also with a long-term treatment plan in mind. And that long-term treatment plan, that evidence-based OAT treatment, because that's what's going to protect them from, their non-fatal and fatal overdose and death from their substance use disorder. All of the supportive care medications are ones that I think are generally pretty familiar with. They're very much symptom-based treatments. So anything that you can think of from the COWS score that's a symptom, generally speaking, we have a medication for that. And so a lot of these medications are going to target, the GI manifestations, the myalgias, the muscle cramping, the agitation, the restlessness, and don't worry about providing these medications, at the time of discharge, for example. These are really just your supportive care bridging medications as you try to treat with other opioid agonist therapies. These will be the things that will help facilitate comfort and treat symptoms while you use your other tools. So we'll spend a little bit more dedicated time talking about Suboxone, which is buprenorphine naloxone. And especially because I think something that can be a bit intimidating to consider is that potential of having precipitated withdrawal with Suboxone. So if you're, well-intentioned and then trying to initiate an appropriate medication, what if it doesn't go well? And what if you have a precipitated withdrawal? And so we'll highlight actually the considerations of managing precipitated withdrawal as well in the section where we cover Suboxone. So very brief review of the pharmacology. It's a partial agonist, which is how it's graphically represented there. And so it doesn't have that same full activation at the mu receptor, but it does bind very, very tightly, and it persists for a very long time, similar to methadone. It also has naloxone in it, which is an antagonist. So you can kind of compare and contrast those pharmacologic medications on that graph there. And so when you do your COWS score, if somebody is in moderate withdrawal, we used to say that was always the perfect way, the perfect protocol, the typical Suboxone start would be for somebody who's in moderate opioid withdrawal. We would start by giving a little bit of a smaller dose and give some repeated doses all within the same day. And we used to say that the 12 milligram ceiling on the first day was as high as we would go. That's generally not somebody's therapeutic dose, especially if they're using fentanyl. However, we were limited within this protocol. I know, as most people know, there's, microinductions and other ways to start the medication, but this was the sort of classic way and is also still very appropriate for somebody who's presenting at that COWS threshold in acute withdrawal. It's a good time to be thinking about starting this just the same old plain way that we always used to. In terms of addressing precipitated withdrawal a little bit, so the reason why we want people in moderate withdrawal for those traditional starts is because of the concern about precipitated withdrawal. Essentially, somebody's overt clinical picture is a proxy for how much activity and activation they're getting at those mu receptors. And we'll talk a little bit sort of in the next slide graphically showing what happens with precipitated withdrawal and buprenorphine introduction, but we want to make sure that we're not displacing or causing an opioid deficit that leads to somebody's withdrawal actually intensifying. Again, fentanyl has made this a little bit more complicated because there is anecdotally more experiences with precipitated withdrawal, even if people do appear like they're in actually moderate opioid withdrawal. So really nice figure. So essentially what's happening in precipitated withdrawal is you have your mu receptors, which are fully activated, used to being fully saturated and full up with these other opioids. However, because of how tightly Suboxone binds here, if there is other opioids present, Suboxone kind of boots them off And then because it's only partially activating, you have this perceived opioid deficit, which actually can produce significant withdrawal symptoms. And so we define precipitated withdrawal as a rapid onset or worsening of opioid withdrawal within 1 to 2 hours following a dose of the buprenorphine. And generally speaking, it'll resolve within a day or so. And it's scary. It's one of the most intimidating parts about Suboxone is thinking you may actually, make somebody feel worse by trying to give them an appropriate therapy. And that's where the cows also comes in. So how do we always figure this out? Somebody can subjectively report symptoms are worsening, but when you trend them, you really see it. And so I just wanted to highlight this graph here. It's a bit busy, but on the left side, you see a COWS score. On the right side is a dose of buprenorphine naloxone, and the shaded area is when somebody started to receive the medication. And so you can see someone was getting the medication at about a COWS score close to 10, and then very quickly, within a couple of hours, it shoots all the way up into the 30s, 40s, being very severe withdrawal. And so that's what you'll see when somebody's having precipitated withdrawal. And that's why it's also important to continue to reassess with your COWS score to really get a sense of somebody's trajectory when you start treatment. So what do you do with precipitated withdrawal? Well, it turns out, like I said, it's essentially the same as what you would do in any other case. So you can go back and use all of those supportive care medications. You also have the option of not doing any further buprenorphine, no further Suboxone, and you can just give them something else like Methadone or a short-acting opioid that's going to fully activate that receptor to alleviate those symptoms. However, we also have this third option, which is to sort of break the mold of the traditional way we use Suboxone. And so the solution proposed to, precipitated withdrawal is actually just to give more buprenorphine, give more Suboxone and try to overcome that effect. And so there's some case series where this has actually been done fairly successfully. And there's also people who are doing this now with the patient's engagement and consent, is if somebody has an overdose that's reversed with naloxone and they go into withdrawal as a result of that, immediately starting Suboxone and giving high doses of Suboxone to get them on therapy, like within the same encounter in the ED. And so just to highlight overall, as we sort of wrap up with buprenorphine naloxone, there are so many different protocols. We don't want you to worry about all of the different formulations, the specifics about these micro inductions, but just to say that, it's a perfect medication to start when somebody presents in withdrawal. Even if you have a case where somebody has worsening symptoms or you're worried about precipitated withdrawal, you can just use all of these same principles to continue on with their therapy. And the last thing we'll show you is just to reinforce how safe and how user-friendly this medication can be, is there's this new idea of Suboxone macro dosing. And so if we exceed that 12-day start dose, do people do okay? So if somebody comes with an opioid use disorder and they get high doses of Suboxone, 28 milligrams, 32 milligrams, do they do okay? The answer is yes. So we don't see sedation or any adverse effects, probably because of that relative activity, the partial agonism. And then some people do end up having precipitated withdrawal. But again, this is sort of a known consequence of using this medication. It's a side effect that we can counsel patients on and have a plan to treat if, worst case scenario, somebody does experience a precipitated withdrawal. So overall, what I want you to take away is that this is a very safe medication. Please do not be intimidated by it. There are so many ways to use it, and we're always learning more and more creative ways to dose and use this medication. Precipitated withdrawal does happen. It can be a bit scary to think about, but you have tools, either your supportive care, further buprenorphine, or another OAT type of medication to manage that successfully. Just to summarize here, so you'll see this slide a couple of times as we fill in all this information. If somebody's in withdrawal because they've missed their Suboxone, you'd have to refer to guidelines for how to restart. But if they're in withdrawal, you could also just treat them as a traditional induction. As we've talked about, there's these other micro-dosing protocols, there's macro-dosing protocols, and if you have precipitated withdrawal, you have some options. So I'm going to hand it back over to John to wrap up some of our other treatment options.
Hey everyone, and actually we saw the rest of your questions on phone everywhere, and I think there was one about microdosing, and it looks like Mike just said Suboxone and is keeping us in suspense. So we could maybe even chat about microdosing now, just generally, or we could leave it to the end. What do you think?
So I think, I don't know what the exact question was. I apologize. Oh, here, sorry. So microdosing Suboxone. Oh, so it's just that. Okay. So microdosing essentially, the way I like to describe it is it's basically a cross taper. And so because you don't want to abruptly kick off somebody's other opioids from their mu receptors, if you introduce that Suboxone slowly, gradually over time, you don't have that jarring change in the pharmacology at those receptors. And so essentially you're just kind of sprinkling in your Suboxone slowly, going up, so that you don't have an abrupt change. But it actually allows you to get to a therapeutic dose with somebody still using other opioid medications. And the idea being that as you increase the Suboxone, you're decreasing other opioid use, and you end up doing essentially a cross taper.
There's an example on the handout. What we will say is technically it's not totally protocolized. You'll see a bunch of different microdosing. You'll see rapid microdosing. Again, there's nothing as formalized as say, wait until they're in withdrawal, then keep giving them Suboxone. And that's why you'll see a few different things. But if you understand the pharmacology, what Laura explained very nicely, instead of kicking off the opioid that was in the body all at once and gradually increasing the buprenorphine on the receptors, so you don't trigger that precipitated withdrawal, then you can at least understand. I think it's something that maybe if one of us is on service or if you can phone a friend, probably something that that they can walk you through in a bit more detail.
And I'm happy to share, there's a fairly comprehensive, a couple really easy user-friendly review papers that have very clear outlines of how to do this. And it's pretty straightforward, to be honest. I see the follow-up is about the half-life. And so the half-life is actually quite long, but because of that partial activation, that's why it's very safe to continue giving more medication. And so the safety profile in terms of those side effects that you worry about, respiratory depression, sedation, we honestly don't see those with the Suboxone. And so that's why that idea of that 12 milligrams is a bit artificial. And so, you know, you actually can give more, and it's that sort of macro dose protocol where you can actually give, it turns out, as much as you want on day one and really not see someone have adverse events. And it helps you get them on that more therapeutic dose more quickly. So we know now that you don't have to stop at that ceiling of 12, but if you did, you know, you would want to continue titrating the next day.
So essentially, and again, I think it says on the handout, if someone say uses 16 milligrams in PRN on day one, day two morning, you just give them 16 milligrams all at once in the morning, and then you can continue PRNs in case they continue to have withdrawal symptoms. And you keep just baking in those PRNs into the daily dose. And like Laura said, Bupe is super safe because of that partial agonism effect. The only time there have been any overdoses, and they really pale in comparison to, you know, what patients would be using on illicitly, is in combination with benzodiazepine. So it's a very, very safe medication, and you should titrate your dose based on what the patient needs. All right. This is why we baked in extra time to the presentation. So if you have any more questions, please feel free to put them into the Zoom. But otherwise, we'll continue to methadone and sustained release oral morphine. So when we were dry running this with Tarek on Wednesday, he said, well, you know, Suboxone's great. And it is. I want to say it's an amazing medication and is very safe, very useful. But not all patients will want to go onto Suboxone for whatever reason. They've been burned by it before with the precipitated withdrawal. They want to keep using on top. You know, they've had good experiences with methadone in the past. For whatever reason, Suboxone just isn't their medication. And so you might have to think about one of these next two options, methadone or morphine, immediate release transitioning to sustained release. So let's talk a bit about methadone. If you understand the pharmacology, just like with Suboxone, you will understand how to use methadone. First things first, unlike buprenorphine, it's a full opioid agonist. So it does have a narrower therapeutic index, and there are more issues with overdose as a result of methadone. Can be used, you just have to be a bit more careful than buprenorphine. The other really interesting feature about methadone is that it's got not only a long half-life, but it's variable from patient to patient. And as a result, it's quite slow to up titrate. If you can think, if you give someone 30 milligrams and their half-life is 24 hours, On day 2, if you give them another 30 milligrams, they actually have 45 milligrams floating around their system. Day 3, they'll have 52.5. And so if you go up too quickly, if you day 1, 2, 3, might cause dose stacking and cause an unintentional iatrogenic overdose. Something useful to know about it, peak plasma concentrations are about 3 hours post-administration. So if you're ever worried about decreased level of consciousness, or you're saying, this patient's kind of septic, not sure if I want to give them their 100 milligrams all at once, you can always split the dose and then reassess them after 3 hours. And of course, as we all know, it's got multiple drug-drug interactions. I'm not going to focus on all of them. You can take a look at this slide after, but just be careful when you're using methadone, or if you're giving someone a medication on top of methadone, and speak to your neighbor, your friendly neighborhood pharmacist. In terms of what to do when you're continuing a methadone dose, number 1, always call the pharmacy to confirm, the pharmacy where the patient gets their methadone. Because sometimes in Connecting Ontario, they'll say that they got their dose when they really didn't, or it will say that they didn't get their dose when they did. So it's always good to get the amount that they received, their timing of their last dose, and what pharmacy they go to. And then this is just the table, again, straight from the BC Centre on Substance Use Guidelines. Depending on how many missed doses a patient has missed, you either can continue the same dose of methadone, or you might need to decrease the dose. Now you can imagine this can be quite tough because it's so slow to up titrate. If someone's on 120 milligrams and they've missed 7 days, they have to start back to 30 milligrams. And if you're only going up by, say, 10 to 15 milligrams every 3 days, they're going to have a huge opioid deficit because it's so slow to titrate. And I don't think it's safe to increase it quicker in hospital, especially without specialty addictions expertise. But if you're just restarting someone's methadone or continuing someone's methadone, all you need is a call to the pharmacy, documenting their dose, and making sure that they're, don't have a decreased level of consciousness. So then you might say, well, wait a second. If methadone is so slow to up titrate, how is that going to be useful? In the fentanyl era, when so many people are on, say, upwards of 100 milligrams of methadone a day to help with their opioid deficit, what am I going to do? Start methadone 30 milligrams and call it a day and say, sorry, that's it? You may as well be giving someone 2 units of Novorapid when they take, 20 per meal, right? So enter morphine immediate release and this idea of something called sustained release oral morphine, or Cadian is the trade name. And again, just to go through the pharmacology, morphine, we all know it's morphine. It's a full opioid agonist. Cadian, or sustained release oral morphine, essentially it's a collection of pellets that release morphine in the GI tract over 24 hours. Don't confuse this with MS-LON, which is a 12-hour formulation. This is a 24-hour formulation, and it allows it to be dispensed daily to reduce the chances of diversion when it's prescribed as an outpatient. Just like with morphine, it can be used if you've got a pretty bad AKI or CKD. And what's really nice about morphine and sustained release oral morphine is because it's got a short and predictable half-life, unlike methadone, it can be up titrated rapidly every 24 hours. So you can help patients with their symptoms much quicker than you can with methadone because of its long and unpredictable half-life. Again, this is just ripped straight from the BC Centre on Substance Use guidelines for missed doses. If those of you who are a bit more keen-eyed might say, hey, the number of missed days is quite a bit more strict than methadone. And again, that's because you're going to lose tolerance quicker because of the shorter half-life compared to methadone. It just doesn't hang around in the system as long. In terms of what to do when someone comes in and you want to use morphine immediate release to help them with their withdrawal symptoms, we would recommend, say, 10 to 20 milligrams every 2 hours PRN. And then just like with hyperglycemia or someone with type 1 diabetes, reassess them frequently with the cows and give them escalating doses if the 20 milligrams doesn't help. For example, if you give someone 20 milligrams and their cows is still quite high, then you could go up to 40 milligrams with the next one. And then if that doesn't work, then 60 milligrams. And I wouldn't go any higher than that just because that's already a pretty good dose. And if you're worried, you can always give me or Laura or someone else with, phone a friend for help at that point. In terms of Cadian or Esrom for a new start, you can start at 100 to 200 milligrams daily. If you're a bit more concerned, 50 to 100 milligrams. And then you can just up titrate by 50 to 100 every day, max at 1200. And importantly, it can be used alongside methadone. I wouldn't increase both on the same day, just because obviously you want to make one change at a time. This is just a summary table, won't dwell too long on it. And a few clinical pearls about using morphine immediate release and Cadian. So when we're prescribing immediate release medications, it's best to use an oral syrup because sometimes patients can hide those in their cheek and divert them or use them intravenously later on. Of course, hold if respiratory rate is less than 12 or decreased LOC as a safety measure. For Cadian or SROM, make sure the pellets are sprinkled into applesauce and witness ingestion, and then keeping naloxone either on the ward or at the bedside, just to keep people a bit more comfortable. There was also a question about, hey, what do I do if there's pushback about prescribing these medications if I don't have addictions expertise? I think, if you want to phone a friend to start off and say, hey, actually, I spoke to this person, or, this is the training that I've had, as long as you keep making small changes along the way, people will become more and more comfortable with these medications. But absolutely, you have to be careful whenever you're prescribing them. And then just a quick thing about injection opioid agonist therapy. Unfortunately, not widely available in Ontario. There are 2 great studies, Naomi and Sloan, done out of BC at St. Paul's, which actually do show great outcomes for patients who are not responsive to traditional opioid agonist therapy. So to summarize, Suboxone, withdraw, give. There's an order set coming to UHN, hopefully at other places as well. There's an order set at St. Mike's. There's this idea of a micro and a macro induction. For methadone, 30 milligrams is usually a safe starting dose for someone who has either missed more than 5 doses or a new start. And then always continue it if possible. If you're worried, you can always split the dose, give them half, and then reassess them 3 hours later after their peak concentration, give them the remainder of their dose at that time. And then for SROM, 100 to 200 milligrams, and then you can go up by 50 to 100 milligrams each day. Again, checking the BCCSU OUD guidelines for missed doses. So going back to this poll, turns out that the correct answer is actually D. Cadian or SROM can be up-titrated every 24 hours. So A is incorrect because Naomi and Salome ran out of BC. Suboxone's not always preferred. It's really a patient-by-patient choice. Methadone no longer requires a special license or exemption from CPSO since 2019. So that's to continue or to start or to prescribe. Not that I would recommend prescribing as an outpatient. And Cadian can be up-titrated after 24 hours. So that was really the meat and potatoes of the presentation. We're in the home stretch now, and we'll talk about how we can facilitate safe transfer of care to the outpatient setting. I think at the end, there was a question about clean needles and sterile injection sites in hospitals. So I think we can address that as well, because that's a very fantastic discussion. So I think the main takeaway point from here is that unless you're comfortable, which I don't anticipate anyone should be, and you probably shouldn't be, to be completely honest, don't prescribe these medications on discharge, and especially not short-acting morphine. And the idea is there's a whole lot of nuances that you need to know about prescribing as an outpatient. A lot of things can go wrong. Not all the pharmacies will know it. So just don't worry about it and avoid, save yourself the page and the patient who doesn't have the opioid agonist therapy. So don't prescribe them on discharge. What makes more sense is to make sure that the patient gets their dose of methadone, Suboxone, Cadian, what have you, on the morning of discharge, and tell them to head to a clinic for a prescription starting the following day. This may, change discharge plans because some clinics are only open Monday to Friday. They're only open in the mornings. And make sure that the following information is included on the discharge summary because the clinic will need to know. They'll need to know the dose of the inpatient opioid received, the timing of that opioid, and it's always good practice to include a patient, go to this clinic so that you can continue the, getting a prescription. Some of the places that you might have heard of, True North, is they've got a bunch of opioid clinics throughout Toronto. There's a bunch of these rapid access clinics, which are drop-in. So you can just tell a patient, go show up and give them a specific time if you think that will help them. If you go to that website, Medify, and search for the RAM clinics, you'll get a list, and you can see there's a whole bunch of them all throughout Toronto. You can see they're pretty spread out geographically. Some of them do virtual care if patients have the capacity for that. So it's just a question of finding one that works geographically and time-wise for a patient. This is just a sample, set of instructions to include for the patient and for the clinic, making sure that the summary is faxed to the clinic as well on discharge. Again, just including all that pertinent information. The dose of the opioid received, the date of the opioid received, and that the expectation is the patient goes to this clinic for an ongoing prescription. Again, I would recommend not prescribing these medications personally on discharge, just because there's a lot of things that can go wrong. And if you're absolutely back up against the wall, phone a friend, either the Round Clinic at your site, or one of us or someone else that who has specialized practice in addictions, just so that we can help make things as smooth as possible. These are just some further resources. The BC Center on Substance Use OUD guidelines, if you just Google it, they'll come up. Really fantastic. They're kind of the gold standard that I think a lot of us use nationally for the management of OUD. BCCSU online certificate, Medify. They also have a webinar on inpatient management of OUD. So in case you found what Laura and I talking about either too boring or too confusing, feel free to watch. Kit Fairgrieve is an addictions doc here at St. Mike's who also did a fantastic talk. So please feel free to watch some of those webinars as well. And for some reason, this is a huge, there we go. I don't know why that one became so big. So we talked a bit about microdosing Suboxone. We talked a bit about when to initiate buprenorphine, titration schedule of weaning off therapy.
That's a really big question.
Yeah, there is no one set schedule, and overall, patients do much better with opioid agonist therapy than off. It's going to be an outpatient question. Usually if patients are stable for 6 to 12 months, you go down over a number of months, you hold them, depending on patient symptoms. I don't know, Laura, if you have anything else to...
Yeah, very patient guided usually, and very much at their comfort. And, as we sort of said, we wouldn't be generally encouraging people to prescribe medications in a way they're not comfortable with on an outpatient basis. And so, I think titration in general, weaning in general is much similar to our other medications if you were to do it in a vacuum, but really should be patient directed and generally not something we would do, I think in hospital.
Definitely not in hospital.
Yeah.
No. This is definitely like an addiction thought. We would be doing it in someone with longitudinal care. And if you're ever unsure, you can always tell a patient to go to a Round Clinic and they'll be able to help out with something like that. What are your thoughts on allowing the use of clean needles? Tarek prepared us for this because he was like, someone's definitely going to ask this. What are you going to say? So thank you, Tarek.
So we'll both address this, I think. So I think one thing that's really important to know is that patients are often using drugs in hospital. We know that, they know that, there's studies about it, there's qualitative studies about it that talk about why, and a lot of it has to do with fear and stigma and concerns in their self-treating withdrawal. And so I think, the real goal for a lot of us in this field is to help people do things safely. And so if somebody is needing or feeling that, they are going to be using drugs in a medical setting. I mean, ideally, we would have a supervised consumption site at all of our sites to facilitate this. But in the absence of that, harm reduction principles, I think, should still apply in our hospital setting, especially because we know that people are using drugs in an unsafe way, in locked bathrooms with going through our sharps container. Like there's so many, bad things that can happen. And it should also be a way to communicate clearly with people about their withdrawal experience. Like if they're not finding that their withdrawal is being managed, if they're still having cravings, for example, then we need to know that as their healthcare provider. And so I think, my answer is generally yes. And I think it should also be a bridge for, further communication and assessing, the adequacy of their treatment.
Yeah. So my answer is pretty much the exact same. I look at it from 2 domains. Number one, if a patient feels unwelcome, they're going to be much less safe, right? If you compare it to, say, sex ed for teenagers, right? Abstinence only. We know that doesn't work, right? So similarly, we need to focus on patient safety, right? Advocacy and patient safety. And sometimes hospital policy doesn't always go nicely with what we know is best for patients. And, that's what it is. So I think practically speaking with the charge nurse, speaking with the nursing team, speaking with the patient, and coming to a mutually beneficial and mutual agreement in terms of setting boundaries and also, making the patient feel safe and understood and heard. I think that's the main goal of it. Secondly, from just a purely practical point of view, if a patient is illicitly using substances in the hospital and they're leaving, they're hiding sharps because they're afraid, that's not great for the nurses. That's not great for the housekeeping staff, right? So this is also a way of protecting, hospital employees, right? If we can, hey, here's a sharps container. Hey, tell us when you're going to use. Tell us what you're going to use so that it doesn't, affect your, or at least we know about the things that you're using so that it won't change your medical care too much, right? From a purely practical point of view, I think we need to improve the harm reduction strategies in hospital. Of course, big ships take time to change course, and hospital policy, of course, it's tough to get out of that mindset, but I am absolutely for advocating as long as all the care partners, nurses, housekeeping, patient, us, our porters are totally on board. Sorry, this is a bit how to manage. Okay, I hope we managed to. Maybe that was Tarek throwing us a freebie. Hopefully, we've managed to talk about how to manage opioid withdrawal and not hyperglycemia. So those were the questions that kind of came up at the beginning, and if you had any more questions, feel free to throw them up now. It sounds like I was kind of peeking at Laura throughout. It sounds like there's been a pretty active discussion throughout, so I'm going to assume that people's questions on chat are good. Did anyone have any specific questions? Tarek's raised his hand. How polite.
So polite.
I know, very, very, yeah. I've never used the raise my hand feature on Zoom.
I wanted to say thanks so much to both of you for a great presentation. I definitely learned a lot, and I think the one piece that was very, very new for me, a lot of this is new, is the not giving the prescriptions. And I will fully admit, like, I've given prescriptions for like 30 days of methadone and long opioid prescriptions just because I did not know that was a thing. And I was hoping you could just elaborate on why that is.
Yeah, it's not that you should never do it. It's just there's a lot of nuances when it comes to outpatient prescribing. Like, for example, Cadian or Esrom, you want to make sure it's daily dispense. You want to make sure it's witnessed, that the tablets open, the pellets are sprinkled into applesauce. Someone should ideally be following for patients on the methadone program, urine drug screen, so that they can eventually get carries or more than, a dose to take home instead of always needing to come into the pharmacy. I think it's a bit complicated, and you're potentially opening yourself up to difficulties, both in the patient not getting the proper, opioid agonist therapy and not being up titrated correctly. But that being said, sometimes your back is up against the wall and, the patient really wants to go and there's no clinic that's open, at which point you can give them a bridging script with daily dispense. Witnessed observed dosing would probably be the safest for methadone and Cadian, until they can see their outpatient provider. I don't know, what are your thoughts?
Yeah, I would say the same thing. So I mean, I don't think it's necessarily wrong to be providing prescriptions. I would think that what needs to be emphasized, and what I would do in almost every case, especially if I wasn't going to be longitudinally seeing someone, is daily observed everything. That's the safest way to do it. Because on the other hand, maybe, if somebody can't get to the clinic, as John alluded to, we don't want them to just run out of methadone or whatever it happens to be, and then, be lost to follow up. And so I'll do scripts for a couple of weeks that are intended as a bridge, to make sure that, somebody doesn't abruptly lose access to their medication. And it's just keeping in mind all of the details that have to be written correctly on your prescription in order for the pharmacy to fill it. So I think as long as the details are there, and as long as there's a daily, it's daily witness, then there's probably not a lot of stuff that can go wrong, especially if you're not sure, are they going to follow up in a couple of days or a week? Like it's sometimes hard to say.
Yeah, I agree. The safest thing probably for you, for hopefully the patient as well, is to just get them rapid follow-up with the RAM clinic. And Laura just reminded me, we will stop the share so that you can actually see us. Hello. Yeah. Any other questions? Thanks, Tarek.
There is some stuff in the chat about acute pain management, comorbid alcohol use disorder. I don't know if anybody had any follow-up questions for those. We've tried to put as much in there as we can.
I have a quick question if there's still time.
Yeah, absolutely.
I'm going to turn my video on here. Sorry, I was eating lunch. Outstanding presentation, guys. That I learned a ton. That was really, really helpful. Hopefully my patients will get some of this knowledge when I'm back on service. Question is I have about fentanyl use disorder and treatment of opioid withdrawal. I'm always worried and never clear. I have no idea what the content, the purity of the fentanyl is on the street. They tell me they use 900 points. And I'm trying to say, is that 5% purity or 100%? And then you have to convert that to morphine equivalents. And it's like, oh my God, help. And just wondering if you guys had thoughts about how to help with that.
So I've been quoting someone who was smarter than me and actually went through the math in great detail. And the rough estimate that they came up with was probably a point of street fentanyl is about 400 morphine equivalents. And so for somebody, for example, who's using a gram of fentanyl a day, we're like thousands and thousands and thousands. And so people's tolerance is crazy, crazy high. And so I've been encouraging more and more people to, it's titrate to effect for some of these short acting things and other medications. Like you don't want to give them 12 milligrams of hydromorphone once right off the bat, but if you're going to give them 4 milligrams and they're like walking around and still mad at you, give them more. So, you know, you can kind of very quickly see somebody's response and see and try to, like we said, maintain that tolerance, because we think, and I'm happy to sort of send that math if you want. It was someone else who did it, not me, but you know, the probably is quite a bit of morphine equivalents.
Yeah, and to chase up on that, Kieran, you're absolutely right. You have no idea what their tolerance is going to be. Like a point of fent, yeah, maybe it's 400 milliequivalents, maybe it's more, maybe it's less. So it's that idea that you have to keep reassessing and escalating or up titrating or down titrating the dose as necessary. Just like with hyperglycemia, right? We don't know what someone's hyperglycemic response is going to be to infection when they're admitted. We change and adjust the dose and keep going up as needed. So it's that constant reassessment with the cows, which is your objective, as objective a measure as you can get.
I just posted a very busy quote that I've saved about the math. It's there for reference, formatted poorly.
So thank you. It's 1 o'clock, so I think we'll wrap it up, but that was just a superb presentation. Thanks so much to both of you, and wonderful to see everybody from the division, and I'll see you next month. Bye.